Hello, my name is Rui Castro. I'm an assistant professor from the Faculty of Pharmacy in Lisbon, Portugal, and I'm also a web editor for UEG Learning. I have the pleasure of being here today with Helena Cortez-Pinto. She's a professor at the University of Lisbon, Faculty of Medicine, and she's an hepatologist at Hospital Santa Maria, also in Lisbon, Portugal. So Helena co-authored one of UEG's Education Mistakes article, Mistakes in Alcoholic Liver Disease, together with Pedro Marques da Costa. So Helena, thank you so much for being here today. I would start with kind of a provocative question about the article that you wrote, and that is if you think that alcoholic liver disease has been somehow neglected or overlooked over these past few years when comparing with non-alcoholic fatty liver disease, because non-alcoholic fatty liver disease now is a very hot topic, is one of the main presence in hepatology and gastroenterology congresses and meetings. So how do you see this?
So, hello. Thank you for inviting me to be here. Well, I completely agree, and I'm sure that alcoholic liver disease has been strongly neglected over the last years. But now we have a demonstration of that. There is a very recent article from the group of Ramon Batalet, where they evaluated the number of publications and the number of presentations in congresses, and it's so short compared with either NAFLD, hepatitis B, or hepatitis C, and that is in complete opposition of the number of deaths, of the morbidity and mortality related with alcoholic liver disease when compared with NAFLD, hepatitis B, or hepatitis C. So it's like you have two graphics in complete different directions. So this impression that we first had just as an impression, now it's very well demonstrated through the evaluation of all the studies. It's published in BMC. The first doctor, I think, is Nguda. And it's really impressive. Still, even in this meeting today, this UEG week, the number of symposiums on alcoholic liver disease when compared with the other diseases that are much less frequent is quite impressive.
Yeah, so it's a good sign. So in these mistakes in alcoholic liver disease, you suggest that enforcing abstinence and engaging patients to really to alcohol rehabilitation programs should be something that a clinician should always keep in mind. But when thinking about this, I think that this indeed has some problems for both the clinician and the patient. So I think the patients always go to the clinician with this desire to get a quick fix, like a drug or a surgical option, something like that. So lifestyle recommendations is not something that they are looking for. And on the other hand, the clinician, I don't know if you agree, if there's a distinction when thinking about lifestyle recommendations and thinking that, for instance, recommending exercise or healthier diets is sometimes that clinicians often think that it's easier and that patients will adhere strongly than alcohol abstinence. So do you want to comment a little bit on that?
Well, I think in what relates to lifestyles, the adherence is far from good also. It's not only alcohol. And in fact, what we have recently seen is that the fact of having a multidisciplinary team makes all the difference in what relates to NAFLD. Yeah. And it's completely different just for a clinician to say something or to have a team and to have a dedicated dietitian, for example, that explains exactly what the patient should do. And in what regards alcohol abstinence, everybody knows that it's very difficult to implement it. The first problem is that the patient recognizes that he has a problem, and that is well known that many patients with alcoholic liver disease do not recognize they have a problem, so they think they can stop at any time. But it has been also well demonstrated that it's the best moment to try to put them in any program is when they have the first physical consequence of their alcohol harm conduct. Okay. So if a patient is discovered by chance that he has some alterations in his liver function that are due to alcohol, but he has not really suffered it, he's not so prone to change or to adhere to a consultation on alcohol. But if he has been admitted to the hospital, And if he has a real complication from his alcoholic liver disease, that's the best moment to refer him to an alcohol team that tries to impose abstinence. So we are now trying to create a bridge that in a way that the patient doesn't leave the hospital without being seen by the psychiatrist team that would deal with this problem. Okay. But anyway, in one of the sessions, we asked the audience who had, in fact, one of these easy references for the patients, and most of the people did not have. So it's a fact that probably most patients that are either admitted or seen in an ambulatory clinic with liver-related alcoholic disease are never referred to an alcohol clinic, just alcohol rehabilitation clinic to take care of their alcohol problem. So I think it's still very much neglected.
Yeah,
yes.
Something to pursue. Also, you were talking about the liver tests, and there's another question that I want to ask you, which relates with the non-invasive tests now, because liver biopsy, there's always this discussion whether you should perform or not a liver biopsy. And there's this trend now towards the validation of these novel tests, non-invasive tests, the liquid biopsy concept. So how do you think this is in terms of alcoholic liver disease? Because I remember from the article series that you wrote that sometimes not performing a liver biopsy could be a mistake in particular situations. So do you want to comment on that?
Well, I think that in the last years, in all fields of hepatology, we have been decreasing the number of liver biopsies. And that's also true for alcoholic liver disease. And in fact, in alcoholic liver disease, and particularly in alcoholic hepatitis, that is a form of presentation of alcoholic liver disease, this is very much true. Many patients would really benefit from having a liver biopsy on that setting, because sometimes it looks like, but it is not alcoholic hepatitis, and this has an effect on the kind of treatment. So it's not just to do a liver biopsy because we want to know, it's because this has implications for treatment. Anyway, this is for the serious form of alcoholic hepatitis. But for the more compensated phases of liver disease, we have now a lot of other non-invasive methods, and one of them, of course, probably the most well-known is the FibroScan. Yes. But the FibroScan has some problems in alcoholic liver disease because it's increased if the patient is actively drinking. So this cannot give you the right information. But still, I think it should be and probably could be more used in the future to detect early forms of alcoholic liver disease, even in the GPs, in the general practitioners area, because this is one of the other problems with the disease. It's that it is only taken in a very late phase. Okay. I'm not sure if the mistakes were that very specifically. I
think you did, yeah.
But in fact, that's one of the problems. We only diagnose the disease on a too late stage. Much later, there's also something that's going to come in the next months, a paper showing that compared to the other etiologies of liver disease, alcoholic liver disease is usually seen in very much advanced stages than NAFLD, hepatitis C, hepatitis B. So only when the patient has his first complication that he's seen.
Okay. Mm-hmm. So, Helena, you are also a member of UEG's Public Affairs Committee, and I know that a key topic in the UE Affairs agenda this year was alcohol. So, do you want to talk a little bit about the work that the UEG Affairs team has been developing on this topic? Mm-hmm.
Well, we have been trying to talk with the MEPs, and also we have a strong relation with Eurocare. Eurocare is an entity that's also related with EASL, the European Association for the Study of the Liver, and they try to change a little bit the European policies on alcohol. But it's a very slow process. We are not really achieving many changes. One of the major points in what relates policies on alcohol is the taxation and the price of alcohol. So one of our major efforts is try to increase, to change the rules to increase taxation. and mostly to have the minimum unit pricing. That's something that is very effective, has been shown to be very effective, for instance, in Canada. But there is a very strong influence to the European Committee and to the European Parliament from the alcohol industry companies. So there's an imbalance in what relates. The other thing that we have been also trying to fight for is the labeling of the alcoholic drinks. I don't know if you already noticed, almost all foods have the nutrition facts. Yes. And alcoholic beverages do not have.
Are not required to.
Besides from the volume, the percentage of alcohol. So the labeling, and also we tried, because this year there was this attempt to try to change the law regarding the audiovisual media and the publicity, most what's visible to the children, but also to the young adults. And it was very important to change it in order that the children would not have so much access to publicity, not only for alcohol, but also for unhealthy foods.
Foods, right.
But so far, it has not been very successful. We were not really able to change almost anything, although we try. We talked to MEPs.
But it's good that there's.
We have done these summits. We are going to do another summit on November the 29th, and in fact, it's my task to present to the MEPs the evidence that we have of the effects of alcohol in the population. It's not only to the liver, but to many other diseases where alcohol is in fact responsible for a lot of deaths and also cancer. Not only liver cancer, but also pancreatic cancer, colon cancer, breast cancer that was recently shown to be.
So it's good to see that there's really like a task force trying to change things. So just before we finish, I would like to hear your opinion on this mistakes in series. So as both an author, and I'm sure you read some of the articles, so how do you see this kind of, we thought it's a different, unusual kind of structural articles, like depicting the mistakes, and we're having really good feedback from people. But so what do you think? Did you remember things by writing it? Do you think it's good advice? Do you think it's something that people can use in their daily practice? So
I think it's very useful. The ones I read, I thought were very useful because, in fact, they are quite short to read. They give a message that is rapidly apprehended. So it's like a learning way that's quite different from other ways. But I really think it's a very, very good idea. And also, I've had very good feedback from my interns, from the younger people that work with me. I think probably it's mostly, but I'm not sure if that's only the younger people, the interns, the young specialists, that really read it and find it very useful. Very useful, mostly because they are short to read and have this strong message. Yes.
Oh, it's good to have that feedback. Thank you. So, thank you so much, Helena. And on behalf of UEG Education, I would like to thank you again for co-authoring and collaborating with us. And I'm sure we will work together again soon. So, thank you so much.
Thank you.
Thank you
very much, too.